Department of Physiology. And Dr. Anjana Talwar is also there. She's in charge for the Respiratory Research Laboratory, where
Hello,
we are doing
everyone.
exercise testing. So now we can we start now?
So, how many participants are there? I think in workshop, I welcome all the delegates who have taken time to join this pre-conference workshop today. As Dr. Geetanjali has said, this workshop is from the Respiratory Research Lab in the Department of Physiology. And I'm the faculty in charge of the lab, and Dr. Geetanjali Bade is also associated with the lab along with me, and we too are managing the lung functions as well as the cardiopulmonary exercise testing. Now we are using cardiopulmonary exercise testing to assess the individuals in for their fitness in health for those patients who have to undergo the lobectomy or some other procedure. So meanwhile, with this initial intro, we are going to start with the workshop. The resource persons today along with us are Dr. Abhijit, who's a senior resident in the department, and Mr. Nishchay, who is working on cardiopulmonary exercise testing in his thesis work and also assisting other students who are doing PhD and MCH. So, cardiopulmonary exercise test to start with. The title is The Principles of Exercise Testing and... Yes, I can see the slide.
Yes, visible.
So is it on the whole screen? It's okay?
Yeah.
So next slide, please. She is the one who is sharing the... I'll be taking a little bit of intro by Dr. Geetanjali. So clinically, exercise testing, why it is important? Because when one is doing exercise, it is not just one system, cardiac or the muscular, but it is an integrated response of our body. So this integrated response gives an idea more objectively regarding our fitness state, and the response of the body to exercise will give an idea of the aerobic capacity. Different clinical tests which are available, which are shown here, are the 6-minute walk test, incremental shuttle walking test, endurance shuttle walking test, 12-minute walking test, and cardiopulmonary exercise testing. Among these cardiopulmonary exercise, the 6-minute and 12-minute walking test as well as the endurance shuttle walking test are mainly submaximal tests, as well as the incremental shuttle walking test, though we can find out it is a maximal test, but we cannot have an measure. So the topic for today is the cardiopulmonary exercise testing. So we'll be going ahead with the cardiopulmonary exercise testing. Yes, please. So as I earlier said, it is an integrative exercise response, practically non-invasive. If you choose to measure bicarbonates or arterial gases, then it could become invasive, but in general, it is relatively non-invasive assessment of the integrative our three systems, that is pulmonary, vascular, and skeletal muscle. In fact, we should say four, the circulatory system also, which are not adequately reflected if we measure the function of individual organ system. For example, if we are measuring spirometry, we will know only about the respiratory system, and that too at rest only. During exercise, if we are able to measure, fine, but that would give only an idea regarding the respiratory system. The resting pulmonary and cardiac function, we cannot give an idea or information regarding the full functional capacity of an individual, and how, when subjected to stress or doing the increased activity as in exercise, how our body will respond cannot be assessed by the resting function. So in order to assess that, the exercise needs to be done. So overall health status correlates better by how much exercise can be tolerated by our body than with our resting measure. That's why it is the wealth of information what you get from cardiopulmonary exercise system is much more than what you get from the resting measurements or from the other submaximal tests like 6-minute walk test or 12-minute walk test. Next, please. So this is an equipment. This is a picture which is taken from our lab only. So this is showing the cardiopulmonary exercise testing system. We have the system by Cosmet, the Quark model, as Dr. Kedar was asking. So I'm just mentioning here. So what we see here are the two screens. On one and another, you cannot see clearly here in the picture, but it will be showing so you can choose what all you can see on the screen. As during the demonstration, you will know. So this is the system which is connected with the treadmill here. So the person is performing exercise on the treadmill. So is the recording of ECG. Along with that, we have the measure from the expired gas. You will get an idea, information regarding how much oxide which is eliminated and the minute ventilation. In addition, we have the probe for the pulse oximetry, so we'll know the SpO2, and then we ask the individual what is his perception regarding the breathlessness or the leg discomfort. So both of them. So these are the minimum requirements that you have the ECG for the heart to assess whether the person is able to tolerate the exercise and the exercise. So you cannot see the whole equipment here, but as during the demonstration, you'll be able to see what all is there in the system to show. There are two sensors which are there. One is for the carbon dioxide and one is for the oxygen to give you information regarding the oxygen uptake as well as CO2 eliminated. Next one, please. So why we should do the cardiopulmonary exercise testing? As a physiologist, we can say that mainly it is for the fitness evaluation as we have. But in addition to it, we need to evaluate a patient having dyspnea. So in order to know whether the patient who comes with dyspnea, it is a cardiac cause or the pulmonary, or it is some other peripheral cause which is responsible for dyspnea, that we can do with cardiopulmonary exercise testing, and also for exercise-induced bronchoconstriction. So this topic, as I said, the exercise-induced bronchoconstriction, it is being done at present in our lab, and Dr. Nishchay will be able to tell you more that how he is assessing it at the time of demonstration. So the person is doing the exercise, and after that you assess the lung functions post-exercise to know increase in the resistance response during the exercise. That is, during the exercise, if the fall in SpO2 is low. Then we have of cardiopulmonary exercise testing is for the pulmonary rehabilitation to know how much exercise intensity is required or prescribed for a patient due having any lung disease. Pre-operative evaluation and risk stratification is also important. This is important to know whether the person is fit enough to undergo surgery. We are these patients, but it can be done before any major surgery, just to have an idea whether the perioperative time he'll be able to tolerate the surgery or not. Then disability determination can also be done by using the CPET, and also to know the response to therapy. Like if a person with asthma or COPD is there and undergoing therapy, then take or VO2 max will tell you whether the therapy is being affected and he's improving or not. Next, please. So these we must know what are the contraindications for cardiopulmonary exercise testing. So as you can find, there are standard guidelines which are given by European Society, and these are some of the absolute contraindications to CPET. In addition to it, there are other contraindications, which will be there in the next slide. But just to enumerate these, if you see, mainly it is those who are affecting the cardiac and the respiratory system, that is acute myocardial infarction, unstable angina, arrhythmias, acute endocarditis, myocarditis or pericarditis, syncope, severe symptomatic atrial stenosis, uncontrolled congestive heart failure, then acute pulmonary embolism or deep vein thrombosis, respiratory failure, uncontrolled asthma, and if the saturation is less than 88% on room air, and acute significant non-cardiopulmonary disorder which may affect the exercise. In addition to it, if the person doesn't cooperate or have any psychiatric problem, then you cannot assess the oxygen uptake. The response would be impaired in these subjects. Next, please. In addition to, we have some relative contraindications like that is left main or three vessels coronary artery disease, arterial hypertension, which is having a BP more than 200 by 120. Now, all these relative contraindications, the clinician has to judge whether the requirement of CPET would be more beneficial as compared to the harm which may occur. It is going to improve or change the course of management of the patient. Otherwise, it is advisable not to do the CPET just to show that we can do the CPET in these patients. So if only it is going to significantly alter the course of management, then we should be doing CPET in these patients, like we're having significant pulmonary hypertension, tachyarrhythmias or Bade arrhythmias. That means any orthopedic condition could impair the response of the system to exercise. Next, please. Can we continue, Dr. Geetanjali? Next slide.
Yes, ma'am.
So when the patient is doing the exercise, then sometimes you may have to stop the exercise in between and you cannot continue. Most and foremost is the request of the patient to discontinue. If he feels he is uncomfortable and he cannot continue with the exercise due to any reason, due to fatigue, due to discomfort, due to chest pain, so we have to stop the exercise immediately. In addition to it, one can judge by seeing if the patient is symptomatic resting segment depression and if chest pain suggestive of ischemia, significant ectopy, second or third degree heart block. So during the exercise, if on ECG you are able to see any of these, then one should stop the exercise immediately. And even the BP, that is, if it becomes more than 240 or 250 systolic and 110 to 120 diastolic, more than, or if at the peak of the exercise, if there is fall in BP systolic more than 81 to 85%, that is, it becomes around 81% in upper exercise was normal or more than 94, then one must stop the exercise. If there is any dizziness or faintness spell and onset of any confusion which is indicated by the patient or a sudden pallor, then also we must stop or terminate the exercise and discontinue it. Next, please. But if none of these problems are occurring, then we must continue and completing, as I said, the oxygen uptake as well as the CO2 which is eliminated during the exercise, and the exercise is being performed and can be performed by any of the two modalities which are shown here. One is the bicycle ergometer and the second is treadmill. So if you both of these can be used, the person can continue the exercise till the maximum can be achieved, that is the V is foremost. In our setting in India, it is cheaper. There is less chance of a person treadmill. He has to indicate to the can't just stop walking. So there is direct power calculation which is possible. The work problem in holding the bars which are there on the bicycle ergometer, whereas for the treadmill, it is advisable that the true work rate will not be assessed if a person is holding the sidebars. So you have to instruct the patient not to hold them as much as possible during the treadmill. And also, some training is required because every day we don't do cycling every day, whereas we are doing the everyday activity while walking. So treadmill is much more the BP recording, much more easily carbonates in between, and also it is the artifacts, the movement artifacts, the bicycle ergometer, and not only the movement artifacts are less, but the ECG also can be read easily, and the quality of the ECG which is produced doing the bicycle ergometry. So these are some of the main advantages for use the CPET or the which is bicycle ergometer, and some of things which one to account when using the test modalities or and advised for that comfortable for now. Bicycle ergometer. There are two types, and the second is ramp. In both of them, actually, there is at each step there is some time for which the same work rate is continuous or the load is continued, then it is increased. So there are steps, and each step has certain time duration which it will continue. Whereas on the other hand, you see the ramp protocol. In the ramp protocol, the perception by the individual that the workload has increased is not there, because it is not a sudden change in work rate which is there in this one particular protocol. And there are certain advantages of this ramp protocol, that the recovery is much earlier in these patients, and because they are not able to perceive the sudden increase in the exercise, they are able to tolerate the whole process and the test much easily. So advisable is the ramp protocol but this ramp protocol is easily done in the bicycle ergometer. In treadmill, it is a bit hard, and not all the models are able to support the ramp protocol, in which you have to know the initial speed, final speed, how much will be the inclination to be increased. So all these things